has a potassium level of 6.2 mmol per liter. Which findings should nurse expect? Select all that apply. So we know in this patient, like, what is the normal value of potassium. So potassium is normal 3.5 to 5. Yes. And if we having 6.2, we are having hyperkalemia. Okay, we are having hyperkalemia over there. So that can be life threatening, because we have studied last week it can cause dysarrhythmias. So do we see muscle weakness in high potassium? Come on guys, just put the answer there. Yes. Okay, so because high potassium level can disrupt the normal nerve and muscle cell depolarization, so definitely we will see the muscle weakness over there. What about tall peak T wave on ECG? Is B correct? Is B correct? Yes. A, B, E, F. Nice. Okay, because what kind of ECG we gonna find in hypokalemia? Will it be flat, U wave, or T wave? What we will find in hypokalemia. The reason why we have tall peak T wave in ECG in hyperkalemia, because increased extracellular potassium in alter the repolarization state. Yes. Okay, so that's why we see T wave. Thank you, Pizza. Yes, definitely in hypokalemia, we're gonna see U wave. Hi, Rugal. What about constipation, guys? C. What is the side effect of hyperkalemia? Is it gonna be constipation or is it gonna be diarrhea? What's gonna happen with the gastric motility here? Anyone? Yes. Okay, we are not gonna see constipation, guys. We are gonna see diarrhea in there, because hyperkalemia increase the gastric motility also. Okay, not constipation. In hypokalemia you will see constipation. Okay, so not in C. Okay. What about D, polyuria? What about polyuria? Thank you guys for following. Really appreciate. Please keep double tapping and sharing. What's gonna happen with hyperkalemia? No. Okay, so especially please understand, when we have hyperkalemia we see oliguria, we see less output of urine. Okay, so we don't see polyuria in that one, because now kidneys functions are not proper and kidney is retaining too much potassium. Okay, so that's why we will see oliguria. Thank you, Pizza. Paresthesia of hand and feet, is it correct? Can electrical imbalance? Yes, you're definitely, because this is potassium can affect the nerve function. Okay, so it can definitely cause the tingling, numbness, pins and needles in hand. So that's very common symptom. And what about hypotension? Are we gonna see hypotension or hypertension? Yes. Yes, in hyperkalemia we are gonna see hypotension. Okay, because when we have severe hyperkalemia it can weak the cardiac muscle. Okay, and when we have less cardiac muscle contraction, it will cause the bradycardia and it will cause the drop in blood pressure. Okay, the heart is not pumping properly, so we will see hypotension over there. Good one, guys. Let's keep moving. Our aim for today is to do 30 questions. Okay, I think that's gonna take us at least 2.5 hours. A patient receiving loop diuretic present with serum potassium 2.8 mmol per liter, which nursing intervention are appropriate? Select all that apply. Okay, so in the last question we know we have done what is the normal level of potassium is 3.5 to 5, and now we are having patient with 2.8, so hypokalemia. And especially if somebody is on loop diuretic, something like furosemide, okay, there are very higher chances of patient to go into the hypokalemia. Okay, so we need now which nursing intervention. Place the patient on cardiac monitoring. Definitely is correct, because patient can go into the arrhythmias. Yes, life-threatening arrhythmias, like you will see U wave, you will see flat T wave over there. You can even see the PVC in hypokalemia. Okay, and patient ultimately can go to the VFib. So continuous cardiac monitoring is good. What about B? Encourage food like banana and orange. Is B good? Yes. Okay, because banana and orange known to have more potassium, so that's why we will do that. Okay, so it can, sometime it will take time. Prepare to administer IV potassium via IV push. What about C? What about C, guys? No, because potassium can never be pushed. Don't push it, okay? Otherwise, we can prepare to do the infusion if required, okay? But if rapid IV push, it can cause the fatal cardiac arrest. Hi, okay? So it should be infusion pump. So C is wrong. What about D? Monitor for shallow respiration. What's gonna happen with hypokalemia? Are we gonna have shallow respiration? Yes, okay, because one of the reason is it cause muscle weakness, and especially the respiratory muscles. When weakened, it can lead to shallow respiration. Okay, and you can see in severe cases, you can even see respiratory arrest in the patient. So we need to monitor, and 90% of time it is the golden rule. When we are having monitoring, it will be good. Okay, it's most of the time it is correct answer. Teach the patient to report muscle cramp. Is it correct? What about E, guys? Yes, okay, because muscle cramp, fatigue, weakness, these are very common symptom of hypokalemia. Because now we don't have uh, good ongoing neuromuscular functions of the body, so we need to teach patient about that, and they need to report. Okay, well done, guys. Let's move to question number 3. So a patient with cirrhosis develop hyponatremia. And today is all about electrolyte imbalance and ABG interpretation. Okay, so please be with us. A patient with cirrhosis develop hyponatremia, 125 mmol per liter. Which assessment finding are consistent with this condition? So we know it is a very common to have electrolyte imbalance, like especially the hyponatremia and cirrhosis, because cirrhosis causes portal hypertension. Okay, and when we have portal hypertension, that will activate the renin angiotensin aldosterone system. Yeah, and then body will start retaining the free water, and that will dilute the sodium into that, and patient will definitely have hyponatremia. Okay, so portal hypertension is doing everything over there, and RAAS. What about seizure? Just study, these will be posting on the YouTube today. Everything is already posted on YouTube that we have done in past. Okay, yes, seizure, because we need sodium. Okay, we need sodium for the action potential of the brain. Okay, so when sodium level drop, what happen? The water diffuse or move into the brain cell due to the osmosis, and it can cause the cerebral edema. So it is going everywhere, wherever it can find the place. Yeah, so that can cause increase intracranial pressure, that can cause confusion, that can cause seizures. So seizure is yes. What about bounding pulse? Are we gonna have bounding pulse? What about B, guys? What kind of pulse we are gonna see in patient with hyponatremia and cirrhosis? What kind of pulse? Thank you, Amita. Thank you, guys. No, okay, we are gonna see either normal pulse or thready pulse. Okay, so it will be weak, thready, or normal. It can be normal pulse also. It will be never bounding pulse. Okay, so B is wrong. Yeah. So you will see bounding pulse more in hypervolemia, not in hypovolemia. Okay. So this one, whenever, because we have hyponatremia, the fluid is gonna move outside from the systematic circulation into the extracellular fluid. Yeah. What about C, dry mucous membrane? We will have dry mucous membrane. No, okay, because we are having hyponatremia, so body is gonna lose fluid. It is not that, especially it is the delusional problem. This is not the actual electrolyte imbalance. This is happening due to the cirrhosis and then portal hypertension. Okay, so we are not gonna see dry mucous membrane in this patient. We will see dry mucous membrane in patient with hypernatremia, not hyponatremia. Okay, what about confusion, guys? Likewise, we already talk about seizures. Yeah. We will already talk about seizure because fluid will leak into the intracranial space and we can see the confusion over there. And hyperactive reflexes. Are we gonna see hyperactive reflexes or hypo? When we see hyper, no. Okay, so this is wrong. We will see hyperactive reflexes in hyponatremia. Okay, hypernatremia, not hyponatremia. Okay, so it is hyponatremia, so we will not see hyperactive reflexes. Okay, because there is less sodium and we need sodium for action potential of the neuron. So if there is less, it will be sluggish. Alrighty, when you will have hypernatremia, then you will see that. Okay, hyperactive reflexes are mostly seen in which other electrolyte imbalance? Yes, T2 King, I can explain. See dry mucous membrane, because now we have less sodium in the body and body will try to lose the fluid. Okay, you know where sodium goes, water goes. So we don't have enough sodium, so body will not retain the water inside the circulation. Okay, so that's why you will not see dry mucous membrane. You will see that one into the hypernatremia, because there is too much sodium and body will try to get water from everywhere. So that's why we will see that one in hypernatremia, not in hyperactive reflexes. Which other? Yes, magnesium. Okay, Vinny. And please, when you guys are answering, make sure today, because it is imbalance one, so make sure you guys put like hypo or hyper. We know it can happen due to any electrolyte, but usually hyperactive reflexes will happen due to which hypo? Hypocalcemia and hypomagnesemia. Okay, so you will not see in hyponatremia. What about headache, guys? So same thing with the headache. Likewise, we discussed we have hyponatremia condition now, and we are starting losing fluid into the extrastitial space. That's why we will lose fluid into the brain cells also, and they will swell. There will be intracranial pressure increasing, and that's why you will have headache. Okay, so headache, confusion, and seizure, they have same rationale. Okay, especially same thing. Why it happened? Because there is less sodium. Yes, there is pressure. Okay, let's move to question number 4, guys. A patient is prescribed spironolactone for heart failure. Which potential complication related to electrolyte should the nurse monitor for? Okay, we know what kind of medication is spironolactone. This one is potassium sparing. Everyone happy with that? And we done this medication in our last live. So we need to make sure, because it only works by blocking the aldosterone, and it will increase the excretion of sodium, excretion of water, but it will retain the potassium. Okay, so patient is at a lot of risk of hyperkalemia. So definitely A is yes. Everyone happy with A? Yes. Yeah, hyperkalemia, because this is one of the action. Hyponatremia, what about B? B is yes. Yes, because this working by affecting the aldosterone, and it will excrete the sodium and water, so patient can easily go into hyponatremia. Hypercalcemia. So usually spironolactone doesn't have any issue with hypercalcemia. It does not relate. Okay, it only work on potassium. It only work on potassium, guys. It does not retain calcium. Calcium has not be affected by spironolactone. And metabolic alkalosis. Why we can have alkalosis over here? Is it alkalosis or is it gonna be acidosis? What about D? Acidosis. Okay. The thing is that alkalosis. Okay, there is bit of confusion. I know. All the other, especially the loop diuretic and thiazide diuretic, they cause alkalosis. Okay, they cause alkalosis because they excrete too much hydrogen ion. Okay, but spironolactone inhibit the excretion of hydrogen ion, so it is gonna cause metabolic acidosis. Okay, this is the only exception you need to remember while you guys are remembering the diuretics. Spironolactone potassium sparing, hydrogen ion sparing also. Okay, it is gonna keep retaining the H ion. Alrighty. Likewise, other one, loop diuretic, thiazide diuretic, they will excrete that. Okay, so they will cause the metabolic alkalosis, but this one is gonna cause metabolic acidosis. So I'm gonna put it wrong. Gynecomastia, is it correct? Do you guys will see enlarged breast in male patient? Yes, yes, definitely. It is endocrine. Okay, because spironolactone also have anti-androgen effect. Okay, so that's why when it is work by anti-androgen, we done that in our last pharma live, so it will definitely cause gynecomastia. Cool, guys, let's move to question number 5. Aim for us is to do 30 question today. Okay, so please keep double tapping. I really want everyone to keep double tapping and make this one at least 20k. We have 77 people watching. Please do double tap, and if you guys can drop a heart, red heart in the, we need 50 heart. There is a challenge from TikTok. The nurse is caring for a patient with hypocalcemia. Which intervention are appropriate? Monitor for positive choastic sign, trozo signs. A yes. Yeah, so we have hypocalcemia. We have hypocalcemia, and hypocalcemia is known, and these sign, choastic sign and trozo signs, are like what I will say, classical sign of hypocalcemia. Okay, so we're gonna see that. Anyone know what these signs are? So in joystick sign, when you will tap the facial muscle will twitch when we will tap on the cheek. Okay, because it will irritate the facial nerve. And Trosho sign is we will have the spasm in the arm by when we inflate the blood pressure cuff. Okay, yeah, the one is with the BP cuff. Yes, that is this one. Okay, encourage increase intake of cheese and leafy green. Do we need to do that? What about B? Do they have calcium? Yes, yes, B is yes, because these food are good source of calcium. Okay, so leafy green like spinach, kale, they are good one there. Do we need to administer IV calcium chloride slowly? It is saying slowly, so that is the key word here. Is it possible to administer? Yes. Okay, so IV calcium should administer slowly. Most of the electrolytes we are doing, you need to correct it slowly. Okay, which kind of vein you can use, which kind of line you can use over here? What about C, guys? Which line you guys can use to administer calcium? Central line. Thank you. Good. Yeah. No, they are different. So what will happen? Calcium chloride we will do slowly with large peripheral vein. It can be, or with central line, because it will reduce the irritation. Okay, it will reduce the irritation. Place the patient on seizure precaution. What about that one? Can patient have seizure? No? Anyone that can have seizure? Yes. Okay. We done that question last question. We talk about hyperactive reflexes. Yes, if you remember. Okay, so we talk about that. If patient is having hypocalcemia, we talk in last question that it will cause hyperactive reflexia. Yes, and when you will see hyperactive reflexia, the patient can go to seizure due to heightened neuronal excitability. Okay, so that's why always put patient into seizure precaution with hypomagnesemia and hypocalcemia. Okay, you will have heightened neuronal excitability, so patient can go into seizure. So D is correct. Restrict dairy products. What about? Yes, all wrong except E. Definitely. So E is wrong because dairy products are high into calcium and it should be encouraged. That's why we are increasing the intake of cheese. Okay, so we need to check the other options also. Okay, there was a question about calcium chloride and calcium gluconate. How they affect, how they work, and are they same? Anyone? Okay, so calcium chloride and calcium gluconate are different medication, guys. Okay, in calcium chloride you will have higher composition of oh, we crossed it over, Ashley. We crossed it over. This is wrong. Okay, this is wrong. So we need to increase. Rest everything is correct. We will increase the cheese because it have more vitamin, or not vitamin, more calcium. Okay, yeah, so we need to encourage dairy product, not reduce. Okay, calcium chloride have more calcium element. Okay, so it usually have like at least, and that we give to promote and to correct the calcium, hypocalcemia. Okay, what about gluconate? What about gluconate? You guys don't have that much calcium in calcium gluconate, okay? Yeah, so that's why. And they have different medication, they work differently, they work on different, the use is different. Calcium gluconate we usually give to stabilize the cardiac membrane. Yeah. Actually, why we do place patient on seizure precaution? Because hypocalcemia increase the neuronal excitability. It will cause the hyperreflexia in the brain, so patient have more chances to go into the seizure. Okay, so hypocalcemia, hypomagnesemia, hypernatremia can cause seizure. Okay, so that's why we want to make sure like patient is on seizure precaution. Okay, let's move to question number 6. A patient with alcohol use disorder has a magnesium level of 1.0 mg per dl. Which finding should the nurse expect? We done similar kind of question before in our last live. It is already on our YouTube. So I should expect these question correct from most of the viewers who are on YouTube. Yes, Torsad is the pointers. Yes. Okay. It is key electrolyte. Magnesium, remember, magnesium is key electrolyte maintaining cardiac rhythm. Whenever there is a problem of cardiac rhythm, magnesium, please check magnesium. Okay. So A is correct. A is definitely correct. What about muscle twitching? We done that. What's gonna happen with muscle twitching? We just talk in last question. Okay, yes, because you are having hypomagnesemia right now. We are having hypomagnesemia. Okay, and what happened with hypo? It increased the neuronal excitability. Okay, when neuromuscular excitability increase, it can lead to the tremors, it can lead to the muscle twitching, it can lead to the spasm. Okay, so muscle twitching is normal. Increase deep tendon reflexes. What about C, guys? Is C correct? No, decrease. Why? Why it need to be decrease? What does magnesium do? What does magnesium do, guys? What is normal range of magnesium? What does magnesium do? Why we give magnesium to patient? Sometimes we use for sedative effect. Everyone happy with that? When we use it for sedative effect? Yes, see? Yes. Okay. Yeah, it can be for adult. It is 1.7 to 2.2. Okay. So C is correct. Okay. The normal level is 1.7 to 2.2. Depends where you guys are. But it can be 1.3 to 2.1. Okay. There are different levels of magnesium. Okay, because magnesium have sedative effect, so when we are having hypomagnesemia, then there is not enough magnesium in our body. Okay, and it can cause the hyperreflexia, and that's why you will see increased deep tendon reflex. Same thing why we see muscle twitching. Okay, so bit of the rationale is same for that. So we are seeing hyperreflexia due to the hypomagnesemia. Okay, and this one will be the first sign. This will be the early indicator of hypomagnesemia. Okay, guys, Hypotension. Do we see hypotension or hypertension or nothing? What about D? No. Okay, we are not gonna see hypotension. We are gonna see hypertension and vasoconstriction. Okay, hypotension is more in hypermagnesemia. Same rationale again. It is increasing the neuromuscular excitability. Okay, when we have more neuromuscular excitability, we are gonna see vasoconstriction, not vasodilation. When we will have hypermagnesemia, then we will see more sedative effect. Okay, and that's where you will see the vasodilation and hypotension. Okay, so that's why this one is wrong. What about seizure, guys? Same thing, same rationale. Don't forget that one rationale, like what magnesium do and what it keep. Yes, okay, again we are having neuromuscular excitability increase, it can cause seizure. Okay, magnesium's normal range is it depends which what you are using. So if you are using like it is 1.3 to 2.1, but if you are using this MEQ per L, okay, but if you are using mg per dl, then it will be 1.8 to 1.7 to 2.2. Okay, so sometimes we just put the initials. That's not good. Like we need to understand where it is. Okay, so whether it's in the liter or deciliter. Yes, one is low. Okay, because this is 1.7 is normal in this situation, mg per dl, so one is low, hypomagnesemia. Okay guys, let's move to question number 7. We will have break at question 10. The nurse review lab result for tumor lysis syndrome. Which findings are expected? What is TLS? Anyone? What is TLS? Tumor lysis syndrome. Anyone? So what is lysis? What is lysis, guys? Tumor has ruptured? Yes. So lysis is destruction. Yes, we know that one. So when we say tumor lysis, that means like there is too much destruction of cancer cell. Okay, so now we are having too much destruction of cancer cell. All the intracellular content is into the bloodstream now. So yes, hello John. So it definitely happen after the chemotherapy. Okay, so most of the time when tumor cells rupture, they will release potassium, phosphate, uric acid, all the content. Okay, hyperkalemia is excess of potassium. Hypercalcemia is excess of calcium. Okay, so hyperkalemia, potassium, we just talk about that. Yeah, so potassium is primary intracellular cation. So when cells lyse break down, it's always released into bloodstream and it always cause hyperkalemia. Okay, so you're gonna see that one. Yeah, sure, Shai. Hyperphosphatemia will be that. Yes, okay. So it's gonna be there. So always remember, so this was cation, this is anion. Okay, so these are two major intracellular component. Okay, phosphate and calcium. Potassium. Okay, potassium is cation, phosphate is anion in intracellular. So when we do the lysis, that's gonna happen. Hypocalcemia, are we gonna see that? What about C? Yes. Why we gonna see hypocalcemia, guys? We know it's yes. We have done that a couple of days ago. Why we gonna see hypocalcemia? Not raised, not raised, not reverse. Low bone density? No, no, nothing. Okay, when you guys give phosphate always bind with calcium. Okay, we done that. Phosphate always bind with calcium. So when there is cellular lysis of the tumor cell, then there is too much phosphate in the body. Okay, there is too much phosphate in the circulation that will bind to free floating calcium. Okay, and now when it's binded, you will not have enough calcium. Okay, it can cause the precipitation, it can cause secondary hypocalcemia also. Okay, so main, yes, high phosphate low calcium relationship, definitely. Metabolic acidosis, D. What about D, guys? Yes, okay, because in the we have nucleic acid, like uric acid in every cell, so that acid kidney will not be able to excrete. Okay, we have nuclei in every cell. When that will destroy, it will produce uric acid, and then that acid will accumulate in body, and you're gonna see metabolic acidosis. What about hyponatremia? Is it any effect? Are we gonna see hyponatremia? No, because mostly sodium is in the sodium potassium doesn't stay together. Okay, potassium is more into the cell, sodium is more in the circulation, so that's why it's not gonna affect on sodium. It doesn't have any effect on sodium in tumor lysis syndrome. Okay, so E is good. So E is incorrect. No binding, no nothing, no relationship. Okay, let's move to question number 8. A patient receiving NG suction develop metabolic alkalosis. Which finding would confirm this? We need tumor lysis syndrome is when tumor cell breakdown. Okay, when tumor cell breakdown. Thank you, Shai. So that is tumor lysis, especially happen after the chemotherapy. Okay. 8, guys, a patient receiving NG suction develop metabolic alkalosis. Which finding would confirm this? So we know, but what should be that pH will be below more than 7.45, and so what is normal pH? 7.35 to 7.45. Okay, so now we are having serum pH 7.52. So A is yes. Yeah, pH greater than 7.45 determine alkalosis. What about bicarbonate 30? What is normal level of bicarbonate? Anyone? Normal level of bicarbonate. 22, 26? Yes. 22, 28? Yeah, I always find confusion in that one because most of the countries have different. Mostly is 22, 26 that they use. Yeah, okay. 30, so that means it is greater. Okay, it is greater, and it is, so when we studied Rome, respiratory opposite, metabolic equal. Okay, so now pH is on that side also, and bicarbonate is also on same side, so metabolic. Okay, that's why it's metabolic, because it is on the same side, metabolic equal. Okay, so that's why it is metabolic alkalosis. What about hypoventilation? What about C, guys? Are we gonna see hyperventilation or hypo? Yes, hypoventilation. Because the thing is that no, we are gonna see hypoventilation because body is trying to compensate. Okay, body is gonna retain carbon dioxide CO2 to lower the pH. Yes, okay. If body will do hyperventilation, you're gonna have acidosis. That's acidosis because body is trying to get rid of that one. Slow shallow breathing you will see in I will do the ABG interpretation at the last, guys, after 30 question or 20 question. Once we will done with this, we will do the ABG interpretation, how to do that. Okay, promise we will do that. So hypoventilation. What about tingling in fingers? What about D? Yes, okay, we are gonna see tingling in finger. And anybody knows why it happened in alkalosis? Guys, please keep double tapping, really appreciate. Anybody know why we have tingling in alkalosis? Anyone? Loss of circulations? Low K. It's not more about K, it is more about not potassium, calcium, guys, calcium. Okay, everything is up. It's always about calcium when we have tingling in fever, especially in the alkalosis. So what is happening? Because there is a shift of hydrogen ion from albumin. So albumin is the protein that we have in our blood that have hydrogen ion. Okay, so when you will see like when we have alkalosis, then that shift is gonna cause like calcium will bind with that albumin. Okay, because calcium is a binding protein, calcium is a binding electrolyte. Okay, more albumin will bind with calcium. So when you will bind it with calcium, then you will have low calcium in the free floating state. And when we have low calcium, then you will see the paresthesia. Okay, like tingling and numbness, especially in the extremities. Okay, I will post video on that. I will definitely post video on that. I will make sure I will post it on YouTube. What about E, guys? Do we see small respiration in acidosis or alkalosis? No. Okay, that is metabolic acidosis. Body is trying to get rid of acid by blowing off carbon dioxide. Okay, so that's why we will see E. Okay, two more questions, then we will have a break. Question number 9. The patient with DKA present to ER, which electrolyte disturbance are most commonly associated? Select all that apply. We know DKA is life-threatening, and most of the time you will see hyperglycemia, acidosis, ketones. Okay, yeah, hyperkalemia, correct. Okay, cause total body potassium deficit happening over there. So when we have the severe acidosis, especially in the diabetic DKA, a lot of potassium will shift from intracellular space to extracellular space. Okay, and that can increase the hyperkalemia. That's why we give insulin also in DKA just to reduce the potassium. Hypokalemia after insulin therapy. Can it happen? B. Is B correct? B, yes. Likewise, in hyperkalemia, we always do the insulin. Yeah, and when we give insulin use the potassium for the sodium potassium pump, and then it will reduce the potassium. So you can see hypokalemia in there. What about C, guys? Hyponatremia. Hyponatremia. Is it common indication? C, no. Anyone? Yes. Okay, C is yes. C is yes, guys. I will explain why. What happened in HHS? If we know these two, if we know DKA and if we know HHS, then we know. Okay, so hyponatremia is like we are having hyperglycemia. Okay, we are having hyperglycemia, and when we know when patient have raised sugar, they will be more thirsty. Body will try to put more water into the extracellular spaces, like especially in the systematic circulation. Okay, body will try to retain too much water, and when we will have too much water over there, it will dilute the sodium, and when sodium is diluted, you will see hyponatremia. Okay, so that is, and that serum sodium is sometime we need to see, because like it's not less sodium, it's too much water. Okay, so that's why we need to be very careful. Okay, the issue here is not sodium, issue here is water. The body is in hypertonic state. Okay, body is getting all the water from the cells into the extracellular space due to hyperglycemia, due to diabetes, and that's why HHS, hyperosmolar hyperglycemic state syndrome, that's why it also affect. What about hypocalcemia? Are we gonna see hypocalcemia? Is it related to DKA? Anything? No. Okay, we don't see calcium and magnesium. They don't have that much effect in DKA. Okay, we only see effect on potassium and sodium. Alrighty, yeah. Let's do question number 10. A patient with heart failure is receiving digoxin. The nurse should be most concerned if which electrolyte imbalance is present. What we gonna happen with digoxin? Potassium? Yes, we know digoxin is cardiac glycosides. We done in our last live. It will work on sodium potassium pump. Okay, it will inhibit the sodium potassium pump on the cardiac membrane. Yes, so then we need to worry. Hypokalemia, will it cause hypokalemia? Yes. Okay, is definitely yes, because low potassium level can increase the binding of dioxin to the sodium potassium pump. They are competing with each other. So okay, so that's why it can increase the effect and risk of toxicity. So that is not, anyway, that is the most critical factor that we need to watch out. Okay, hypokalemia, always worry. Alrighty, thank you guys for the roses. Hyperkalemia, what about hyperkalemia? Be yes or no? No. Okay, so we don't need to worry about hyperkalemia. We need to worry about hypokalemia actually. Okay, in hyperkalemia, if there is too much potassium, it will stop the binding of dioxin to the pump. Okay, it will not increase the toxicity. Okay, it will not increase the toxicity. It will just, yes, low potassium. Okay, thank you, triple. What about hypomagnesemia? Is magnesium has any effect? Yes. Okay, so magnesium and potassium goes same way. Okay, it goes same way. Hypomagnesemia can also increase the sensitivity of heart to dioxin, because we know magnesium work on the rhythm. It is one of the electrolyte that is responsible for the rhythm. Yes, potassium, magnesium. So that's why hypomagnesemia will increase the toxicity. Hypercalcemia. What will happen? What calcium do? What calcium do? No, we need to worry about. So this, the question is not related to dioxin to here. The question is more related to contractility. Thank you, Med Humor. Really appreciate. Okay, if you already having hypercalcemia, patient already have higher chances of, hyperrhythm. So that's why you will see if dioxin is there and hypercalcemia is there, it will increase the risk of toxicity, cause high calcium level will increase the effect of dioxin on myocardium contractility. Okay, so hypercalcium is yes, only hyperkalemia is wrong. Okay, really appreciate guys for all the